And now, if our next panel can come forward. Wherever your heart desires, Kalahn. All right, while they're assembling, I will just briefly introduce the chair for this next session. Ben Bluml, who is Senior Vice President for Research and Innovation at the American Pharmacists Association Foundation. Ben has over 2 decades of experience as the principal architect for the patient care models at the APHA Foundation, over 12 years of pharmacy practice experience, and I think over half a decade now of very active collaboration with the National Forum and with a number of other organizations through the National Forum. So Ben, we consider you an important partner, as we do each person on your panel, and we'll now turn it over to you to lead us forward.
Okay, great. So we'll
Time begins
we'll start.
now.
Are we done? The clock is now running. So what we wanted to do was to start, and I'm going to invite each of the panelists to provide self-introductions. And I'm encouraging them to essentially provide you not only with information about the organization that they're representing currently here today, but about the breadth of their experience that brings them here to actually share their perspectives. Because I think that's important for all of us to hear before we get started so that you can understand their intent and where we're each coming from. So, Kalahn.
Okay. How do we turn this on?
Just push the voice button,
Okay.
and there you go.
Hello. How's everybody doing after lunch? Okay. I am Kalahn Taylor-Clark. I am the head of public affairs at Sanofi for the Diabetes, Cardiovascular, and now established medicine unit. And I actually didn't realize that I had a lot more in common with everybody in the room than I thought, so I'll just give it a real quick breakdown. I was a Navy wife for 10 years. We served in Yokosuka. Thank you. I am black, I'm white, I'm from Maine and Chattanooga, Tennessee. I have a son who's 6 years old, and I work very, very hard to make sure that I keep up with him as well as do all of the work that I have to do, and I think a lot of people can relate to that. I also, as mentioned, am the president of the board of the Prevention Institute, which is a not-for-profit organization out in Oakland, California. We have offices in LA and in Texas, here in Washington, and in Oakland. But I come serving on this panel as the head of public affairs at a pharmaceutical company. And I think it's really important that I offer all of those sort of what I might call strange bedfellow experiences to bear on how I see the work that I do, but also how I see the work that we all have to do, which is that oftentimes we actually have to have conversations that are much tougher than we would like. We often have to have conversations to get just to the right vocabulary to then begin to actually make change. And it's my hope in my life and my life's work to make sure that every time I'm actually deciding on where to go and what to do, especially in my career, that I'm challenging myself to think beyond the choir. I have a choir in the Prevention Institute. I've been doing public health for 22 years. I'm passionate about upstream determinants and social determinants of health before anybody started talking about it. But I'm really happy that we actually do have this discourse and this dialogue in a room of, sorry, excuse me, I've got a little cold, in a room of healthcare providers and health practitioners. So I appreciate being on this panel, and I hope that wasn't too long of an introduction.
Perfect.
Okay.
Perfect. Tripp.
All right. So John actually challenged me and mandated that I be provocative during this discussion. As an emergency medicine physician, I think my concept of provocative is a little different than the provocative stuff we talked about before. But hopefully, if we get too boring up here, we could talk about removing things from people that aren't supposed to be there, because everybody always asks me about that for some reason. Don't know why, but it's a question we get all the time. So it's good to be back, actually. I think I was here 3 or 4 years ago as a speaker and representing Health and Human Services for the state of South Carolina. I'm an emergency medicine physician. I still practice a little bit. I was working at HHS under Tony Keck, who actually was from Louisiana. We talked about that with some of the group last night. and focusing more on policy and legislation and some innovative things that he was doing in a very conservative state in a very unique way. At the same time, I was serving as the chief value officer for a large integrated delivery network, and left there to come over to BlueCross BlueShield to really never saw myself working in commercial, although I had some I guess, government insurance, if you will, with Medicaid. I never saw myself going over to the commercial side, didn't know much about it. But somebody that really was a public health figure in my life who, to me, was kind of the North Star of where we should go, how people should act, even in ways that I knew I wasn't doing myself. He was always pushing people to go that direction. He went over there and served as the chief medical officer, subsequently got recruited up to a higher position, and I said, here's a guy, if he's a guru, I know his heart, I know how he feels about healthcare, I know how he feels about public health, and he's in an insurance company. There must be something over there. And so I can't represent the insurance world. I can just tell you about our, situation. But they recruited me to come over, and it's interesting because we have a CMO, and then I'm the innovation officer, and the two of us report up to him, the senior vice president. The CMO really does a lot more of the traditional, I guess, insurance side of medical management, and we have a great kind of triad to try to make things different than they've been in the past. One of the things that he came in and did right away was to say, we're going to focus everything on the quadruple aim. That was his background. That's what we're going to do. And so even our strategic goals and plans as a division, which is called Healthcare Innovation and Improvement, are all aligned, and they have to align back to the quadruple aim, or they don't go anywhere. And so that was a little bit unique within the insurance side. And a lot of the discussions trying to get leadership to understand kind of where we wanted to go. It's been fantastic. It's been I've learned a lot. It's really interesting when you go back, and I think we had a conversation last night about if you told me I would be here at some point, I would say you're crazy. There's no way you could have mapped my career. I think every day I just try to find a place where I learn something and I can add some value. And so what do I do? So I guess if you asked half the organization, they would say I'm the chief disruptor, and maybe more than half. I sat down with my president after about a week, and he said, how's it going? There's 3 specific things they wanted me to work on. And I said, but what's the bigger picture for me? Because it really was kind of a leap of faith for both of us. And he said, I want you to fix healthcare. And so I laughed, right? And I, looked back up, and it was... And so I was like, well, but like what part? He goes, all of it. And so we got a great relationship, but his intent was pure. He said, you got a background in a whole bunch of different things except commercial insurance. And if we're going to solve this, we have got to collaborate. We've got to bring people together. None of us know the answer, but we want you to go try. And so I haven't done it yet, and I know I can't. It requires all of us. But I do think a single person can start things that can make a difference. I do think that single initiatives can build into other things. I don't think that one policy is going to fix everything. And I think the journey from where we are to even policy development is important and doesn't need to be forgotten. So we can talk more later on, but that's kind of my introduction.
Awesome. Kat?
All right. Good afternoon, everybody. My name is Kat Davis Ahmed, and I'm Vice President for Policy and Outreach at the Familial Hypercholesterolemia Foundation. You're all going to be asked to say that 3 times quickly at the end of the panel. But in the meantime, we'll just say FH. For those of you who don't know, FH is a genetic condition that causes very high LDL, the bad cholesterol, from birth and leads to early cardiovascular disease. The good news is it's very treatable. With early intervention, we can prevent heart disease, bypass stents, and death, early death. But 90% of people with FH are not diagnosed. So what brought me to the FH Foundation is a nonprofit research and advocacy organization. We're patient-driven. We're very much a partnership of healthcare professionals and patients, taking a data-driven, innovative approach with a lot of collaboration around the world, but also with the public sector, the private sector, the nonprofit sector, and partners like the National Forum and everybody that you bring together to try to solve this problem. The reason I think maybe we might care about FH in this room is that I think it's an example of what we might be able to do. the research done at NIH, for example, way back in, I'm sure before the 70s, but certainly in the 70s, on people with familial hypercholesterolemia led to our understanding of the role of cholesterol in heart disease and the development of heart disease. From the study of this population, we understood how important cholesterol was. We understood how to treat it. Treatments like statins have now reached millions of people around the world and probably saved millions of lives. Meanwhile, with all those tools we have at hand, the ability to diagnose and to treat FH, 90% of people with FH are not diagnosed. I talked to a woman last week who lost her 46-year-old fiance to a sudden massive heart attack, completely unnecessary had he been diagnosed and properly treated. So I think it's an example of what we can achieve, what tools we have at hand, and if we can succeed with FH, then I think we can succeed with so many other things. What brought me, you say you're surprised that you got here, what brought me to this work, I started working in post-conflict reconstruction on the Mekong River in Cambodia and moved to Bosnia, where I also helped to rebuild a health system in a small town. And I say about the work that I do at the FH Foundation in post-conflict reconstruction, I think everything can be undone in a moment, unfortunately. I hope that in the work that we do, as we progress, that those accomplishments that we achieve cannot be undone, that they'll really build on each other and create a cycle of success. So I'm thrilled to be here, and I thank the National Forum for another great meeting. Thank you.
So, and as I got to know each of these three people a little bit better in preparing for this, I was absolutely humbled by their life experiences and by the expertise that they bring to the table. So hopefully those introductions were helpful in creating some good context and helping to understand their intent and where they're coming from. So in the work that we've done from a foundation perspective, essentially, I'm a big Don Abedian fan, so for me, everything is structure, process, outcomes, okay? And I know that this young lady next to me is a big fan of Don Abedian, too. So what we've done over the last 2 decades to implement a whole series of successful initiatives, because my job really has been to imagine, design, implement, evaluate, publish, and communicate about patient-centered, team-based care. And the challenges that we have out there in our delivery system of the fact that we really don't have enough healthcare providers on the planet to get the job done, and so we've simply got to find smarter, more effective ways to work together, is how do you assemble a team that's going to work, and how do we create structure and process models that take a principle-centered approach to what's going to happen in each community where we're implementing, while simultaneously doing something that's diametrically opposed. That's not getting in their hair about how they get it done. In fact, that's arming them with resources, tools, insight, and opportunity to actually sort out their own how at a local level. So, in Jim's countless examples that we've already heard about, if somebody came in and suggested to him exactly how he needed to do things, I'm sure that would be a little less well received than if he's in a position to make those decisions on his own at a local level. Yet if we're implementing a national program, we have to have consistency and predictability in the patient experience all across the spectrum of the implementation. And so it has to work at a local level and it has to work at a broader system level. And so I want everybody to keep that framework in mind, because I know that it's contributed not only to our success, but to a lot of individuals and organizations' success over the years in terms of moving these kinds of things forward. So we're here on this panel to essentially add on to what we've already heard about the innovations to get back on track from this morning. So we had a handout to go along with each one of these. So Dr. Sidney's report is here for you. Then we had the Heart Healthy Communities, and the incredible work that's being done in Green Bay was profiled. And so glad to have you here, Mayor, and hear your stories up close and personal. And for our session, we have this handout, which you have in your packet of materials, which is what is FH? And we'll talk about this later on in the flight pattern, but we've got a new model that together the different groups within the National Forum have worked very hard to create a shared decision-making model that we think will be a helpful set of tools and resources to fit into that structure, process, and outcomes framework that I was describing. So that's the general context, and now here we're trying to talk about innovation to enhance value and access, and to really add on to the work that's been done, or to heighten awareness about the work that's been done by the National Forum in that context. So our original plan was to have a fireside chat. We're less the fireplace, but hopefully we'll be able to have the same kind of chat. And I'm also a big Covey fan, so everything's begin with the end in mind. And I also like to talk about inventing a preferred future. And so what I'm going to ask each of the panelists to do is to tell us, in their way of thinking, if it were a perfect world from a value and access perspective, what do they think it would look like? So, Kalahn.
Yes. I would not be working for a pharma company. I would not be working for a healthcare company. I would not be working for a healthcare delivery system. I would be part of a community that was about health. That's the end for me. And that's as simple as it is. The way to do it in my mind is through a lot of what we're doing today in terms of talking about this, and I'm going to keep saying it over and over because I was a professor before this, so I say things in threes. But I like to bring strange bedfellows together. I like the idea that we're all sitting in this room from many different vantage points, and that this is really where that conversation starts, so that you can put me out of business. So you can put my company out of business, so you can put the hospitals out of business, so that we can actually have resources that are directed, and I can't see where the de Beaumont guy is, but we can have resources directed in the places they need to be, so that we're not taking care of a sick care system. We're taking care of a health system, and that's my goal.
I know. I don't want to follow that one. You want to go next? That was great. From a clinical standpoint, I thought about this earlier. I worked this weekend, and I actually had this conversation. You're going to think I'm making this up from what you said earlier, where I was teaching an intern the quickest way to kill a cockroach in a patient's ear. Because it's really not the cockroach in the ear, it's the scratching that drives people crazy. And so you need to kill it quickly to get it out. I shouldn't be teaching people that, right? I didn't learn that in med school. Someone taught me that, in the ER. And we see a lot of it in peds. We really do. And so I guess I'd like to do emergency medicine. I do love trauma. Bad things happen to good people. I think if you came in and saw, and there's numbers, and we were talking about we have to be data-driven, but if you squeeze the numbers hard enough, you can squeeze them in the direction where you already have a decision made. And we see a lot of that. But if you look in the emergency department, there's a lot of people there that it really is back to whether you call it social determinants, whether you call it social needs. It's all related to people and their needs, as humans. And so I guess from a vision of what my clinical world would look like, it would be that it is truly, emergency medicine and not all these other things. I don't know if I have as clear of a vision that you articulated, other than the fact that I think our approach would be different. Because even if we snapped our fingers right now and everything was perfect in a value-based world, we're flawed human beings, we're going to screw it up. And so I think the process is important. But we would stop blaming each other and stop taking a perspective and trying to shove it down somebody else's throat, showing that they're a bad person if you just did this, whether it's the doctors, whether it's the employers, whether it's the payers, whether it's pharma. We got to stop doing that, because I think it takes 3 steps back and then maybe we make a step forward. But it's just so painful. And at the end of this, at the end of my career, I don't want to be worn out. Even if we got good stuff done, I don't want to be worn out. So I think we need to stop blaming each other. I did like the concept, shared earlier, how we devolve to pills and procedures. I think we have to dive into the pills and procedures issues to figure out the bigger problems. But we can't just try to, force procedures and make it all about the medical side either. And so I guess the end point to me would be where, and we talked about this on the phone, but my answer is completely different. So it shows you how quickly things change. I think it would be just the process we go through where we are having conversations like this, bringing, as you said, strange bedfellows together. Through my career, I have found that when I was a doctor, the dark side is administration of the health system, right? And so I ended up there. And then at that time, still maybe it was Medicaid, because Medicaid's not paying enough. So I went into Medicaid. I didn't mean to, it's just where I ended up. Now, you could argue I'm on the darkest side there is. On the insurance side, every place I've gone, I've realized there's great people trying to do good things. And by making assumptions about the other side, we're hurting what the future, how quickly we could get to that value-based future. That's all I got.
I don't know what to do here. Those are both hard to follow. I think coming off of our last panel discussion, I think in sort of there may be like the big picture and then the more in the weeds perspective. In my perfect future, we would be spending time and resources on the right things so that families would have more time to spend, you know, taking advantage of the parks and walking with the mayor and cooking healthy dinners, as I think so many on the panel made the point. And if we could spend that time, you know, my grandfather used to walk home for lunch every day from his job at Kodak. He got his cardiovascular workout in, and he got his lunch at home with his wife, and he still had a successful career. And we don't live in that world right now, and I think that's a shame. I think also if the healthcare professionals could spend the time with their patients to explain to them not just what I think a lot of us already know, but also things like, you know, if you have high cholesterol, what does that really mean for you and what can you do about it, instead of the 5 minutes that they have and then people spend their time on the internet getting bad information that counteracts what their doctor told them. I think as much as I love Kalahn's description, I don't want to live in a world where there aren't innovative therapies, quite frankly, because I have familial hypercholesterolemia and I spend a lot of time with people who have familial hypercholesterolemia, and without pills and shots and things like that, there's, you know, we'll die young. So there's a lot we can do with our lifestyle and our diet and all of those things to take good care of ourselves, but sometimes we need more than that. So I want to make sure we have the resources to do that and to take a more holistic approach to patients so that we take the time to say, okay, here are all your options. Right now we're too siloed, and the incentives I'm sure we're going to talk about are not aligned in the interest of good care of people. So I wish that we could align the incentives and take a more holistic approach and have the time to do that.
So great. So when we think about value and access and the different types of innovative therapies that are out there today and that we know are going to be out there or need to be out there, I'd like for each of you to just react to and reflect on which of those categories and which of those therapies do you believe are most challenging from a value and access perspective?
So I am from Sanofi. We have heart therapies, and I represent Sanofi and Regeneron. My colleague Amanda is actually going to be on the board of National Forum, which I'm very excited about, starting next year. And so one of the therapies is exactly the therapy that one of the therapies that Kat might be describing, which is going beyond some of what exists today. So what I would say is the difficulty of going to these more innovative therapies, biologic types of therapies that the general public would say are quite expensive drugs. So we have this problem, this issue all the time about these drugs that are very, very expensive to buy. They're also very, very expensive to make. And the question then becomes, how do we actually develop a value framework for making sure that Kat's life can be saved by that drug? Making sure that not only is it created, but that it's actually accessible, and that it's accessible in an affordable way. And so in my mind, those would be the therapies where we have people that absolutely need the drug to survive, beyond diet, exercise, and all of the other things, and which, by the way, won't necessarily help a genetic predisposition, right? And if we can focus on those types of therapies that are doing that, I think those are the highest value therapies. Then the question becomes, how do we pay for it? And I think when we're talking about value and access, I think that also gets us to the question about population health and a question about, so who are we talking about here? And what we're always trying to think about is the quality versus the cost. And ultimately, when we're looking holistically, for example, and I'll say for a PCSK9 or for some of these biologics or these new products that are coming on the market that are innovative, what we actually have to think about is who is the appropriate person? Who is the appropriate person to get the right treatment at the right time? It's not everybody that has high cholesterol that should be getting some of these therapies, and yet there's a perspective that we should just be going out there and, doctors are going to start doing this and they're going to start treating everybody with these very high cost therapies. In fact, I think if we can actually get to the appropriate patient populations, the ones that absolutely need them, that's the first thing to getting to that high value healthcare delivery of the therapies. I think the other part, though, is that as we are thinking about adherence and keeping people and allowing people to be able to actually live their lives and get onto these therapies, we have to find ways that can actually keep them on for their whole lives. That doesn't have them going through a system where sometimes they get dropped for treatment because the payer drops them because now they're doing well, or because, so we have to be having those conversations constantly, and that's why the strange bedfellow concept is so important to me. But that's where I would answer. I would say that the highest value therapies are those that are going to save people's lives, not just now, but that have genetic predispositions or otherwise, but that also we can identify the appropriate people that need those therapies. That's what I would say.
Okay, awesome. And I think that tags on nicely to what I remember. I think Betsy was talking about we need to meet people where they are, so we need to assess what each individual person's needs are and to sort that out, both therapeutically, and from a clinical perspective, but also behaviorally from a social perspective within their communities. Tripp.
Well, yeah, so I think through things completely different after your answer changes with the stuff I was thinking before, but what popped in my mind from a clinical standpoint for the physicians in the room is standard of care. And I struggled with this when I was coming through, and I was working in, as a third-year resident, I was moonlighting in a small ER where literally after 6 p.m. you were the only doctor in the whole county. The standard of care there is different than the standard of care where I am working at a level 1 tertiary referral center where I have everything at my discretion. And if I don't get it quickly, I have the right to get mad. There, it was nuts. If certain tests, if I really felt like we needed that test, I had to call Harold. Harold was the guy that would come in from his house, pick up the blood, and drive to the next county to get that test done. It's a different standard of care. And the reason I bring that up is, hopefully I can make the connection, it made sense in my mind, was that, I don't want to focus just on the therapies. It's kind of how we go about it. And that you're absolutely right. Not everybody needs everything. And and I don't know all the answers. And so one of the things that I've done is, and I stumbled into this, was I do have to speak a fair amount. And a lot of times it's to the other bedfellows. We might have to drop.
Yeah. Well, no, just keep it going.
Yeah, no, okay. Yeah. I'm going to say something inappropriate and I don't mean to.
Okay.
So I'm going to link something together and it's going to be bad. So, but I'll meet with large employers. And coming over from the primary care, from the healthcare side, I always thought of the insurance companies as the ones that was determining kind of what was going on, who's getting paid for what. And now I'm meeting with, the large employers, and it's amazing what they know. It blows me away when I sit down with the SVP of HR, the CEO of a large manufacturing company. They understand healthcare better than my own colleagues within the hospital. And so I was like, well, why is that? Well, because, especially in my world, I'm focused on sick care. They're focused on their costs. And the insurance company is, maybe the one that we all, including myself, might get mad at from time to time. But I think from the last census data, it's about 58% of our insurance is employer-sponsored. And then it's like 56, 58%. And then it drops down, 19, 18%. But it's over 65% is total kind of non-government. I think 5% or 4-point-something% is within the military. And so I just ignored that as a physician. I didn't realize, wait a minute, these are their funds. So now I have to sit down with them, and they're making these tough decisions. And it's tough because their employees are their families, and they're looking at these high-cost meds, and they're like, okay, help us with this. Because, our health, we have to assume abundance, one of the IHI principles. Does everybody agree we have enough money within healthcare? Within the whole system.
18% of GDP headed towards 20.
If you get our GDP, it's the 5th largest country. Just what we spend on healthcare is the 5th largest country if you just looked at GDP. So we have enough money, I would say, right? So it's crazy how much money we have within the system. So if we say that, someone mentioned this earlier, maybe we're just not putting it in the right places. But how do you decide? Who gets to decide? And it always breaks down when it's you or your family, when you try to look at it from a population health standpoint. And, I mean, I got 2 kids. I would do anything for them. Anything for them. And I would be very upset if I felt like somebody was blocking something that they needed. But then I sit down with these employers, and they're going, how do we decide? We're not able to pay people because of our healthcare costs. Starbucks pays more for their healthcare costs than they do for the beans to make the coffee. And so these are tough decisions. The only way I've found any success is when we sit down, is if I have the opportunity to speak to a group, I'll say, let's look at this from the CEO of a health system perspective. Look at their decisions they're making, some of which, are the flawed reimbursement methodologies, where you make $10,000 for a surgical procedure, but you make $100 for ambulatory preventive care. So how do we flip that? Back to your incentives. I think that's the best, and even from a consumer standpoint, where 80% are covered by employers, and therefore, if I'm an employee, I might have 20% at stake, but it comes out of my paycheck. I don't even really think about it. And so how dare someone actually say I don't need to go to the ER because it's closer and more convenient than my primary care office or my primary care doctor. So I'm kind of rambling a bit, but I think it's the only way we're going to get there is to really stop and say, okay, let's look at the individual problems, but we have got to first say, how am I contributing to this, and how can I help?
So your question is about innovative therapies and what's the most challenging. And I've been thinking lately, like I heard a great talk on the cancer moonshot. Everybody's heard of the cancer moonshot. And all the great research that's out there and innovation that promises to save people's lives if they have cancer or heart disease. But maybe some of the highest value care is in innovations that happened 20, 30 years ago, right? So if we think of statin therapy was an innovation 30 years ago, we know it's effective. We know it's safe for most people. We also know from a recently published paper that about 80% of the people who look like they have familial hypercholesterolemia, which means they have super high cholesterol, they know they have high cholesterol. About 50% of them are on a statin. 50% on generic, cheap, safe, well-studied medication. So there's an innovation that's 30 years old that we are not taking advantage of. So to free up resources to pay for newer innovative therapies that are expensive, maybe we can all work together to optimize downstream and figure out who are these right patients. And I think the only way to do that is to work together and share information and get on the same page, because not everybody with high cholesterol, not even everybody with FH probably belongs on a PCSK9 inhibitor, at least as far as what we know right now. But we're not even, and there's a paper on the VA, the use of statins in the VA population with high cholesterol is also very low. There's a huge missed opportunity. So I think we should make the most of the innovations we already have. Before we we should keep creating innovations, but I don't really understand what it's all for, if it's all just going to sit there and not be used.
Okay, great point. So from a national forum perspective, for all of us as participating organizations from a value and access perspective, our key objective is to enhance the health and well-being by supporting people's access to evidence-based care and what's appropriate for them. So when we think about that, I'd like each of you to reflect on just an example, a case, kind of some qualitative evidence that really bubbles up for you as an emotional heartstring tugger that helps us all to understand the importance of this objective.
So I don't know if I have a heartstring tugger, but I do have a way of working. And the way of working and the way that and the things that I now, because I have a budget and I have resources to be able to bear on trying to solve some of these problems, is to really be thinking about how do we bring coalitions together. And this is something that the National Forum has done incredibly well, especially the Value and Access Forum. And that is that, you know, and I'll say strange bedfellow, I'll just keep saying it, together to solve the common problems. And one of the reasons that that's so important to me is because we're all sitting in the room defining the vocabulary together, defining the problem together, and defining potential solutions together. And so for me, coming from a pharma company, being able to hear, for example, the value and access work stream that has been put together has been really instrumental in even our thinking about how do we actually work with payers? How do we work with others across the aisle to actually think beyond what we're doing to get access to patients, to get patients access to our therapies? So Amanda and I do a whole bunch of work with various organizations throughout the United States, trying to bring awareness about disease state, trying to bring awareness around conditions. But it's really where the rubber meets the road when you're bringing the payers and the manufacturers and the providers into the room together, in this example, to really move the needle. And I think those kinds of coalitions are exactly what help us to move the needle. And so that is, it's not a heartstring, not a tugger, but I would say these are the kinds of things I hope we can all invest in more. Because I think that they are instrumental in actually helping us to create a foundation for moving on this value paradigm.
I think it's great.
So I got one maybe the other way, maybe not a tugger, but just an emotional moment for me when I first started at BlueCross. And so again, I'm an emergency medicine doc. I probably meet every one of the stereotypes of an ER doc. I'm most uncomfortable when I'm not in charge and when I have to sit down and sit still for a period of time. And so I'm pretty comfortable with chaos. I kind of like it. Sometimes some people would say I invite it. It was my, I want to say, second or third week, and I was actually traveling around with another medical director to a very, very large national client. And I was just observing, or so I thought. And they were going through, it was kind of an annual review of, you know, where the healthcare costs were going, you know, what the interventions were. Everybody's struggling to have real outcomes and not just, you know, process metrics, but we're trying to get there. So it was going pretty good, and I'm loving it. Everything is going fine. And then they said, well, our CEO wants to come in. And so our medical director that was there, that I was just supposed to be watching, had a phone call and ended up having to walk out. CEO comes in, and you could tell he was ticked off when he walked in the room. And he sat down, and he was like, all right, I want to go through this. And y'all know the HR stuff. The HR, they're not supposed to know exactly all the stuff that we know because of HR rules about who's sick. He literally leans over and he points to one of the top 10 high-cost claimants that we had been reviewing and kind of what happened and how we could have intervened. And he says, that was my best friend. He will never come back to work again. He will never have a meaningful life with his family, and it's your fault. And I was like, my fault? How is this my fault? And he said he went to a small hospital where the doctor who they had just hired had only done 5 of these cases. How he knew that, I don't know. He said, do you have that data to show that he should not have gone there? It's my 3rd week. But I'm thinking we probably do from a claim standpoint, could match that back up, looking at the procedures. And he said, I know I'm being tough on you, but in the future, don't let my people go to dangerous places. And I was going, well, I can't tell you out loud what I was thinking in my head. But that flips everything on its head. All these things started going through my head of, well, wait a minute, I'm with the insurance company. Yes, we have that data, bless you. But if I'm a provider, now all of a sudden I'm intervening with the hospitals. I still work in the hospital. I was just an administrator. How's that going to work? And so, but we have the data. The hospital, unfortunately, I understand why they hired that surgeon. Surgeons make money. Surgeons help them pay the salaries of their employees, which are skyrocketing. I understand their incentives. But this is going to be very, very complicated. And so I guess that was probably one of the most emotional things, because right out of the gate, I had it thrown at me, and I was really ticked off at the medical director, who fortunately got up and just walked out. I think he must have known it was coming. But yeah, I mean, this is complicated stuff. And I will say, I was making the comment about the standards of care, and we had a good conversation last night with Dr. Robinson talking about, let's look at what the evidence shows. Let's recognize that evidence changes all the time. The primary care doctors, we have a lot of specialists in here in this field. They get bitter with the evidence, because as soon as they get it figured out, it changes. And so how do we make it easy for them to make those economic decisions? Because sometimes I see large employers who are really, really struggling, and they're in a different economic standard of care than another employer. They're both trying to do the right thing, but one of them is looking at going out of business. And so for them to have exclusions and to cover things, I mean, they want things really, really tight. And you try to work with them to say, okay, we don't want to put you out of business. We need some processes in place. How do we make sure that the processes for appeals are smooth, which is something we're working on? And then I'll tell you the other thing that I wish you mentioned earlier about what the world would look like. I had a physician hang up on me, which ticked me off, because I really still feel like I'm a physician. I'm a practicing physician. And when I called them to let them know that their member had called us, it's kind of a VIP, because their procedure had gotten denied. I asked, it's not my area, but because it was a VIP, they said, would you look at this? It had not been appealed. She had just called them and said, you need to call the insurance company and tell them this is crazy. So we went back and looked at it. She hadn't documented any reason why it needed to happen. And then when I called the member and talked to him, and he told me what was going on, it was the wrong test. It was the wrong test. He actually needed a more expensive test. So I called her just to say, hey, here's the deal. I'll approve it, but I don't think you need a CAT scan. You really need an MRI, because if you get the CAT scan, it's not going to show anything. And she said, I'm not talking to the insurance company, and hung up. And so in my ideal world, we actually would want to work together to say, wait a minute, I'm not just going to assume the other side wants money or wants to push meds, that they actually have the intent of the patient in mind and the population.
Great. Kat?
Well, I love that. I think we should all be talking to each other and sharing information. I think insurance plans have a lot of the information that we're all looking for. Like, what's this? I looked up, decide between which big lab to go for my cholesterol test this week. And I wondered, what was covered and how much would it cost. And I went to my healthinsurance.com, and there it was. And I think, I was in a meeting not that long ago where somebody said, we need a big project so people have that information at their fingertips. I said, well, actually, it's at your fingertips. If you trust your insurance company and you call them, they might have information that's actually helpful to you. And their interests may not be completely in competition with yours. But you want a story, I'll tell you a story. So sometimes it's true that the physicians prescribe something or order something and they don't provide the backup. But it's also true that sometimes they provide all the backup there is, and the insurance design is such that it's built to make it hard, quite frankly. So I have a guy who's a volunteer with us, and he gave me permission to share his information. So he's in his 30s. How many know what your LDL cholesterol should be? Say below 100, Dr. Robinson, would you say at least below 100, maybe below 70? So your LDL cholesterol, your bad cholesterol, should be down by 100. Fair to say? This guy's LDL cholesterol was 420. He was 33 years old. He'd been complaining to his doctor of heartburn for a year. That got worse while he mowed the lawn. And his doctor gave him heartburn medication. He had to advocate for himself to get a stress test. He was untreated. Nobody ever said, oh my God, your cholesterol's so high. This is really unusual. Maybe it's genetic. Maybe it's, he was vegan. He was trying to do everything he could himself. So he ended up with bypass surgery at age 33. And he kept advocating for himself. He got on the highest dose of a high-intensity statin. He got another drug that's generic added on. His 420 went to 160, which is fantastic, but 160 is really far from 70, right? So he's the perfect candidate for additional therapy. His doctor prescribes a PCSK9 inhibitor. His insurance company says no. You have to try this other statin that's actually, there's an FDA warning against that statin at that dose. Luckily, his pharmacist, thank goodness for pharmacists, said, no, I'm not filling this for you. There's an FDA warning against it. And that was in the peer-to-peer with his insurance company. That was what was recommended. So he went through the whole process. We tried to help him out, and he got on what he needed to get on, and now his LDL is like 30 or something. So that's wonderful news. But from an FH standpoint, or from like a precision detection, like how are we going to find the right people? This guy entered a genetic testing program that we have, and it turns out he has the rare form of FH. He has 2 genes from both of his parents. And so he wouldn't have found that out from his doctor. He wouldn't have found that out even in the process of getting the medication. And he's precisely the kind of person who needs this kind of therapy. So I think, if his insurance plan would talk to us and understand who they should be looking at, then, our doctors, it wouldn't be talking to me, that would help us all do a better job.
Yep. And one of the principles that everybody agreed to in the value and access effort of the National Forum was this notion of aligning incentives. And in particular, what I can say from our organization's perspective is that aligning the incentives for patients, for healthcare providers, and for payers at a minimum is essential. Yeah. And we broadened that as we talked about this from a National Forum perspective, and we want to make sure that it's also even more broadly inclusive to make sure we get the pharmaceutical manufacturers and other key stakeholders, everyone across the spectrum involved. And what I'd like to do is to kind of have, jump into more of a interactive discussion where I want to invite each one of the panelists to talk about their notions related to aligning incentives after I kind of give just a broad brush overview of that, and to invite the audience to have some back and forth with each one of them as we go down the road to really make this hopefully an even richer dialogue that's going on. But for the payers who have the courage to change the way that care is being delivered and paid for, what we usually tell them when you implement a patient-centered team-based care model is that they too can spend less in total. But they have to have the courage to make the change. So in our diabetes work, for example, you waive the copays for the patient. So the insurance plan the health plan has to pay more. The self-insured employer pays more. Essentially, medication adherence goes up because they were probably, on average, at best case, 50% adherent beforehand, and now they're north of 90%. So now the plan's spending more money on medications. And there are new providers involved in the process. We see an increase in primary care visits. We see an increase in different healthcare providers getting on the team. But at the end of the day, we see people going to the emergency room less. We see people going to the hospital less. And when you do the math at the end of the day, that change essentially usually results in, a range of, $1,000 to a few $1,000s per patient per year, depending on the study that you look at, where essentially just those simple changes actually bend that cost curve, and they reduce the overall total cost for care when people are actually willing to be thoughtful enough about analyzing it. So when we think about these incentive alignments, we have to get out of our silos, and we have to think about the patient holistically, we have to think about the system holistically, and we have to look at the big picture. But what I'd like each of you to do now is to talk about those incentives from your vantage point in your current role, and really be an advocate for, the pharmaceutical manufacturing perspectives, for the health plan perspectives, and for the consumer and provider perspectives. Kat will she'll get both words in there.
So I wanted to do just one quick one. This is personal in terms of thinking about aligning incentives, and then I'll go to what I would think a pharma company would be thinking about. And so recently I started I went to this community health center named Mary's Center, which is here in Washington, D.C. If you haven't ever heard of it, please look it up. It's amazing. And the reason it's amazing is because we sat there, we were a group of 20 people, and it was like, you know, Brookings people and think tank types and vice president types, and we all sat in the room to listen to what Mary's Center had to offer. And one of the things that they pointed out was a 2-for-1. And it was for every one insured person who goes and gets their teeth cleaned at Mary's Center, 2 uninsured people are covered for their dental cleaning. You realize that my son and I both went the next week, right? Because we're insured people. My son is 6 years old. He needs his teeth cleaned. I need my teeth cleaned. So we go to Mary's Center, and now not only do I have an incentive to be a patient at Mary's Center and to be part of Mary's Center, even though I have insurance and I don't think that's supposed to be for me. It is actually for me. I'm part of a community now where I'm not only being able to get my teeth cleaned and get the care I need, but I'm able to give back too. And it's an incredible idea, an incredible thought, right, that we could actually shift and align these incentives to really actually move people in places they want to be. So that was the first thing I just wanted to note about aligning incentives. From a pharma perspective, one of the things that I've actually had the opportunity to do, being autonomous and being from the position in which I am, is to invest differently. And so we were here, and there's a couple of folks in the room that were here with me on Monday, in this exact room, where we just announced the National Association, the launch of the National Association of Community Health Workers, something that Sanofi and I in particular invested in 100%. We didn't get any other people investing in this program, but now there is going to be a national association of over 40,000 healthcare workers, health workers, not just healthcare workers, health workers that are going to be part of a system. And then the question was always, well, why would a pharma company invest in a National Association of Community Health Workers? And it took me a little while to think about, well, what would that look like? And so the first obvious low-hanging fruit, the incentive was, well, we could improve adherence, right, to our therapies. We can improve, especially for diabetes, cardiovascular patients, we could improve adherence if we have these community health workers who are both, quote-unquote, culturally competent, knowledgeable, and linked to the community, but that can help them to navigate, quote-unquote, a system. But it went beyond that to me. It went beyond the idea that we are just promoting this idea of adherence for therapies. The incentive alignment for me as a pharma company was to ensure that we are caring for the patients. In this case, it's patients. And when we talk about population health, we had the old school patient beneficiary, and now we really are gone beyond that, right, to geography. But if we were just talking about the patients right now, that not only are we able to make sure that patients are adherent to therapies, but we are absolutely offering a wraparound for people to not just be patients, but to be able to live in their neighborhood, to be able to access various resources, not just the healthcare delivery system. And it is, in my mind, the pharmaceutical company where we have the resources and the ability to do so, to be able to provide that service to what we call patients, but for people that we serve. And so that's the kind of aligning of incentive that I think a lot more companies are doing, can do, want to do, maybe don't know how to do, maybe don't understand how to actually align it. So you just jump and hope that it's going to work. And this was a really good example of that. We had about 150, Cassandra, about 100 people in the room the other day, and it was warm, and it was amazing, and it was wonderful. And it was an opportunity for us to be thinking across what we would have called silos before, to be able to actually bring the folks to the room and to the table to actually solve a problem that is incredibly important, at least to the communities that we're serving in diabetes and cardiovascular, which are usually minority and underserved communities. So that was what the incentive and the alignment of that incentive was for me as the representative from a pharmaceutical company.
Great. Yeah, Tripp, payer perspectives here.
Yeah, so, and again, if I did even a mediocre job of telling you kind of where my focus is, it's outside of the day-to-day typical things within the insurance company. Two examples, and then hopefully I'll make a cogent thought here. When I was at HHS, there was a big push, and actually a personal to the director connection to loosening some of the restrictions around behavioral health. And he pushed for that, and he did it. And we didn't know this was happening until we started to see the budget go like this, where hundreds of providers moved into the state or set up shop and started performing this service, and literally it wrecked the budget. We ended up having to close other programs because you have a set amount of money that comes through the legislature, and a great intention caused some deviant behavior of others. And I say that because the other thing is we're talking about, when you have to regulate things at a very high population health level. We know this from a clinical standpoint, screening tests, there's a false positive and a false negative. You're going to catch some, right? There is nothing that says in this exact case it'll apply to every situation. The rigor or ridiculousness of those measures to catch sometimes depend on how bad the outcome could be. It could also change back and forth depending on the economics of what's going on with that group or how much that med cost. What I have tried to do and been freed up, because that work is still going on. It's going on across the, hopefully the world, but definitely the U.S. with the way we're set up, is re-envision it. How can you have the people at the bedside align their incentives with the patient and the employer? And so one of the things that we tried to do was to say, okay, let's build new networks. Let's have a new product where we go to the employer and we say, your trend last year was X%. Your healthcare trend is this. Very few people consistently is going down or flat, it's this. So if we guarantee your trend with everybody who signs up for this program, we will be at risk for that. Well, how's the insurance company going to do that? You have to have providers to actually do that. So we said, we'll go to the providers and say, are you in? We're in, we'll share the risk. If we come under that, then we'll split the savings or however you want to do it. But at a very high level, here's a population. It's the employer's money. If it's under that, then we share it. If it's above it, then we also share that. That gives them the incentive to work with the patients to say, and to actually ask the questions. I walk around in the ER all day long, and not one time in my entire career has anybody stopped me and said, hey, do you really think about how much that costs? But if I'm responsible for that, now I can start to make some different decisions. Where I can say, you know what, yes, it is more convenient for when I'm going in to do a lac repair for 4 boats of 4x4s to be open. That's really convenient. But if now I'm thinking about the population of paying for a medication that's really expensive, this has now been cut down as far as the importance. I'll tell you really quickly, it's a journey and you go to different health systems, some are ready, some are not. Some of them say, oh my gosh, this is the right thing to do, but we're scared. We're not sure we can do this. The administration says we're not sure we can trust our physicians to do this. This is completely different than the way they thought about it before. We're used to doing everything. Everything's at our discretion to use any med, anytime. And it's not until those those restrictions and regulations to curb that kind of catch people that it causes some chaos. So that's what we're working on. That's where my charge is, to say, how can we build new networks to align those incentives so that the patient and the doctor can have the discussion about what's needed and not have to have these other regulatory burdens that stop it. It might be pie in the sky, but that's what we're trying to do.
So in terms of aligning incentives, I think there are a few principles that I think I believe in. I'm sure many of us do. We all have a personal responsibility and an interest in a sustainable healthcare system and a part to play. I think transparency and building trust, and I think a lot of the efforts that the National Forum has made to bring us all together like this, but also in the work that we've done over the past couple of years to understand each other better, it builds trust so we can understand, where are you coming from, where am I coming from, what are our interests, and where do they align. And I think we can go a long way there. I think unfortunately our experience is that the physicians are paying attention to the cost of things. I sat next to a cardiologist at the American College of Cardiology when outcome results were announced for one of the drugs, and she just shook her head and said, nope, not prescribing, too expensive. So she's made a decision for her patients that actually doesn't have anything to do with what insurance will cover. And so, I think there's more than just the insurance plans putting a wall around what's available and what's discussed with patients. What I love about what we built is a shared decision-making tool, because I think people need to know, maybe people are willing to pay out of pocket, or maybe, with more transparency, they would know, what does this cost? What does it cost that I'm not taking my cheap generic drug. So I think transparency, trust, and personal responsibility.
Yep. And to that point, if you look at this word, it's all about shared. And in order to have sharing going on, there needs to be trust, there needs to be communication, there needs to be collaboration. And I think that, I think one of the best ways for us to kind of end this, and I don't know if we'll have time for questions or not because we run a little bit long here, but not overtime just yet, is that we've got to communicate our ways to success. And that's just the simple truth of it. So, John, your pleasure. You know, open it up for questions or call it even? One question. John says one question, so.
Why are you overly restricting
I
us?
thought we were
This is crazy.
utilization management
Yes.
of questions and
Lining
This
the
isn't a value.
incentives.
Now he's up to
I
2.
only have 1 minute left.
Hi, Lindsay Vidiniaks with the Alliance for Patient Access. I help manage a working group for physicians, clinicians who care about the sanctity of the physician-patient relationship. And so I guess just a question for Dr. Jennings. We know that in South Carolina, I think for 54% of policyholders, PCSK9s have been denied. And so, you know, as I go and talk to my physicians and nurses, they keep saying, you know, I'm only prescribing it to the correct patient. What more can they be doing to make sure that they still have that trust relationship, but that they're not having to, as Kat mentioned, you know, decrease the time with patients because they're spending so much time on paperwork?
Again, that's why I said I'm blessed that I get to work on the other side to say let's reinvent the world. You know, there is no perfect solution, especially when you're talking about a huge number, right? And we know, as is very well laid out here, not everybody needs those meds. And so if you dive back in and see, okay, what's going on? I mean, this is anecdotal, so I hate to even say it. What I have been asked to do sometimes for backup when I look to see why something has been denied, it really is documentation. But then that's a pain in the butt because every doc here knows and nurse as well, documentation is killing us. Better systems integrated, but we're all scared because, you know, one of my data scientists who's from the South always says the data don't know because the data that can be used for good can also be used for bad. And so every time we talk about connecting systems, then a daggum breach happens and someone tries to do something bad with it. And now I can't get anything through IS security, you know, even sharing back, you know, directly with them. There's things that we could do because the doctor prescribing whatever med doesn't know some of the other claims. We could send them those claims and show them those other diagnoses, other meds that they're on, all of that stuff. We could push that back into their EMR to make it easier, but it's extremely expensive, and then you get the lawyers. That's the one group we haven't talked bad about this time, is it? So I love lawyers. So it's I'm joking. Yeah, it was. Don't call me out on it. But anyway, so I think we got to sit down and look at it and not paint broad anecdotes as these are the problems.
Okay. All right. Well, I'm going to turn it back over to John at this point and appreciate everybody's attention here.
Thank you.
Thanks.